Renal artery stenosis. A stenosis of more than 50% may be observed on imaging of the renal arteries in up to 20% of older patients with advanced kidney disease. However, a hemodynamically significant effect will be present in only a relatively small proportion. Renal artery stenosis is the most common cause of secondary hypertension, with an estimated prevalence of about 2% in unselected patients, but this may increase to 4% in older patients who have evidence of atherosclerotic disease elsewhere. Most cases of renal artery stenosis are caused by atherosclerosis, but fibromuscular dysplasia involving the vessel wall may be responsible in younger patients. Rare causes include vasculitis, thromboembolism, and aneurysms of the renal artery. Pathophysiology. Renal artery stenosis results in a reduction in renal perfusion pressure, which activates the renin-angiotensin system, leading to increased circulating levels of angiotensin II. This results in hypertension by provoking vasoconstriction and increasing aldosterone production by the adrenal, causing sodium retention by the renal tubules. Significant reduction of renal blood flow occurs when there is more than 70% narrowing of the artery, and this is commonly associated with distal post-stenotic dilatation. Atherosclerotic lesions are typically ostial and are associated with more widespread atherosclerosis within the aorta and other vessels, particularly the iliac vessels. There is often concurrent small vessel disease in affected kidneys due to subclinical atherothromboemboli. As the stenosis becomes more severe, global renal ischemia leads to shrinkage of the affected kidney and may cause renal failure if bilateral, or if unilateral in the presence of a single kidney, ischemic nephropathy. In younger patients, fibromuscular dysplasia is a more likely cause of renal artery stenosis. This is an uncommon disorder of unknown cause. It is characterized by hypertrophy of the medial fibroplasia, which narrows the artery but rarely leads to total occlusion. It may be associated with disease in other arteries. For example, those who have carotid artery dissections are more likely to have renal arteries with this appearance. It most commonly presents with hypertension in patients aged 15 to 30 years, and women are affected more frequently than men. Irregular narrowing, beading may occur in the distal renal artery, and this sometimes extends into the intrarenal branches of the vessel. Rarely, renal artery stenosis may occur as a complication of large vessel vasculitis such as Takayasu's arteritis and polyarteritis nodosa. Untreated atheromatous renal artery stenosis is thought to progress to complete arterial occlusion in about 15% of cases. This figure increases with more severe degrees of stenosis. If the progression is gradual, collateral vessels may develop and some function may be preserved, preventing infarction and loss of kidney structure. Conversely, at least 85% of patients with renal artery stenosis will not develop progressive renal impairment, and many patients die from coronary, cerebral, or other vascular disease rather than renal failure. Unfortunately, methods of predicting which patients are at risk of progression or who will respond to treatment are still imperfect. Now, the clinical features. Renal artery stenosis can present in various ways, including hypertension, acute pulmonary edema, progressive renal failure with bilateral disease, or a deterioration in renal function when ACE inhibitors or ARBs are administered. Although many patients experience a slight drop in GFR when commencing these drugs, an increase in serum creatinine of 30% or more raises the possibility of renal artery stenosis. Acute pulmonary edema is particularly characteristic of bilateral renovascular disease. It typically occurs at night and is associated with severe hypertension, often in the context of normal or only mildly impaired renal and cardiac function. Clinical evidence of generalized vascular disease may be observed, particularly in the legs and in older patients with atherosclerotic renal artery stenosis. Clinical features associated with an increased risk of renal artery stenosis in hypertensive patients are summarized in box 1522. However, given the risk of imaging and angiography in patients with renal disease, further investigation should only be performed if intervention is being contemplated. Now, investigations. When appropriate, imaging of the renal vasculature with either CT angiography or MR angiography should be performed to confirm the diagnosis. Both give good views of the main renal arteries, the vessels predominantly involved and the most amenable to intervention. Biochemical testing may reveal impaired renal function and an elevated plasma renin activity, sometimes with hypokalemia due to hyperaldosteronism. Ultrasound may also reveal a discrepancy in size between the two kidneys. Although this is insufficiently sensitive or specific to be of value in diagnosis of renovascular disease in hypertensive patients. Management. The first-line management in patients with renal artery stenosis is medical therapy with antihypertensive drugs, supplemented where appropriate by statins and low-dose aspirin in those with atherosclerotic disease. Interventions to correct the vessel narrowing should be considered in young patients aged below 40 suspected of having renal artery stenosis, those whose blood pressure cannot easily be controlled with antihypertensive agents, those who have a history of flash pulmonary edema, those with accelerated phase malignant hypertension, those whose renal function is deteriorating. The most commonly used technique is angioplasty. The best results are obtained in non-atheromatous fibromuscular dysplasia, where correction of the stenosis has a high chance of success in improving blood pressure and protecting renal function. Beyond the indications above, angioplasty and stenting is now rarely performed in atherosclerotic disease, as randomized trials such as Astral and Coral have produced no convincing evidence for overall benefit in terms of renal function, blood pressure control, or cardiovascular outcomes. The risk of angioplasty and stenting include renal artery occlusion, renal infarction, and atheroemboli from manipulations in a severely diseased aorta. Small vessel disease distal to the stenosis may preclude substantial functional recovery. Presentation and clinical features of renal artery stenosis. Renal artery stenosis is more likely if hypertension is severe or recent onset or difficult to control. Kidneys are asymmetrical in size. Flash pulmonary edema occurs repeatedly. There is peripheral vascular disease of the lower limbs. There is renal impairment. Renal function has deteriorated on angiotensin converting enzyme inhibitors or angiotensin II receptor blockers. This is the figure of renal artery stenosis. A magnetic resonance angiogram following injection of contrast The abdominal aorta is severely irregular and atheromatous. The left renal artery is stenosed, the arrow showing the stenosed area. Now, acute renal infarction. This is an uncommon condition that occurs as the result of sudden occlusion of the renal arteries. The presentation is typically with loin pain of acute onset, usually in association with non-visible hematuria, but pain may be absent in some cases. Severe hypertension is common but not universal. Blood levels of LDH and CRP are commonly raised. The condition may be caused by thrombosis of the renal artery or by thromboemboli from a distant source, when occlusion may occur in branch arteries distal to the main renal artery. This can cause multiple infarcts within the renal parenchyma of both kidneys, which may be visualized by CT scanning. If occlusion of the main renal arteries is bilateral, or if there is occlusion in a single functioning kidney, the presentation is with AKI and the patient is typically anemic. Patients with bilateral occlusion usually have evidence of widespread vascular disease and may show evidence of aortic occlusion, with absent femoral pulses and reduced lower limb perfusion. Management is largely supportive and includes anticoagulation if a source of thromboembolism is identified. It is sometimes possible to perform stenting of an acutely blocked main renal artery to try to restore renal blood flow. In most cases, however, presentation is too late to salvage renal function.